another opportunity to do clinical cases. We love bringing these cases forward each month, and we're going to go back to the emergency department ultrasound scrapbook, one of my favorite places to go. So this case, a 30-year-old male with abdominal pain around midnight, right? Common presentation. How bad could it really be? Let's see what happens here. So abrupt onset, left upper quadrant pain for 3 hours. Doesn't radiate, really no other unusual symptoms, no fever, chills, no nausea, vomiting, diarrhea, constipation. Fell off a ladder 11 days prior from about 10 feet, okay? Mm-hmm. But did well. It was actually seen in the clinic with scapular pain a few days earlier. And then he's been working really without any difficulty.
And no diagnosis on that scapular pain?
No, just showed up, some pain there. I assume he must have had normal vitals in the clinic.
Is it really scapular pain, or is pain radiating to his scapula?
It's hard to know. Here he is, right? So again, broad differential, male with abdominal pain, young person, distant history of trauma. I mean, could he really be bleeding?
Yes.
From a fall 11 days prior?
Sure.
Still?
Sure. I mean, the differential is still wide, and that might be a complete red herring, but it's certainly possible he has a delayed splenic bleed or something like that.
Let's see a little bit more here. So it's just about midnight, vitals, so he's a little bit soft, hypotensive, 89/62, pulse 88, afebrile. He's got some left upper quadrant pain. That was really the only notable finding. And I think the machine must have come in with the clinician, because that's really the only way that happens. So as the nurse was getting the vitals, just started doing the exam.
As it should be.
Yeah. So here we are, right?
Yep.
Just a quick constellation. So what we can see up here in our right upper quadrant, just a bunch of free fluid around the tip of the liver, right? And then...
Spleen.
No, that's right upper quadrant.
Right upper quadrant, thank you.
Yeah. Then here's the spleen, actually. And I don't really see too much up there. But again, this injury happened quite a while ago.
You're talking about injury to the spleen?
You can see it's a little bit hypoechoic there, but I mean, I didn't see a bunch of free fluid up there.
Yeah.
And
I found that a lot of times when someone has an injury to the spleen, you don't see any fluid over there. Maybe because there's clot over there. I don't know, but it seems like you're more likely to find fluid elsewhere.
Yeah. And he's been up and around and doing things.
Yeah.
Obviously, something changed tonight. Who knows what? But then free fluid in the suprapubic. And it's just that standard approach, right? If we were just focused on the left upper quadrant, not looked at other areas, we just go through all the abdominal windows, no matter what you're looking for. It really depends upon the clinical question, but we can look for free fluid, we can look at the gallbladder, we can look at the kidneys. I mean, all sorts of things, but it all starts with these foundational exams. Pretty quick case.
Now, wait, I just want to make one point about that, too, and that's that, it's not our job to determine what parenchymal injury exists there. And the whole notion that you'd have blood near the injury isn't true at all. And this is probably a good example. There's probably a splenic injury with right upper quadrant predominance of blood. You got to be careful not to say I think it's a hepatic injury because of that. Mm-hmm. Okay?
Yeah, so we get some more blood, some pain control, transfer to tertiary care, and then ultimately a CT showed multiple splenic lacerations and got IR embolization. So certainly a delayed presentation. And I've seen patients come in when I've done TART reviews, and their injury will have happened 4 or 6 hours earlier, and they'll be like, I didn't bother doing a fast exam. I just sent them right to CT, because if it was something bad, I mean, they would have exsanguinated by now. But it's just part of the routine evaluation. To bring the machine in, get the images, and you can really move things along.
So do they fix the scapula? No. So by the way, that's called Kerr sign, and a subdiaphragmatic irritation from blood that you feel in your shoulder.
So it was a great case.
All right. Sometimes if you get a better look at the spleen, you can see blood above it. It's hard to see blood above the spleen, but I would go look, but it doesn't really matter. You do the same thing anyway.
So if you're doing that call, you're about to transfer them, and your surgeon says how much blood is in there, what do you tell them based on those images?
Well, we know that to have fluid show up in Morrison's pouch, you need to probably have 700 mils in your belly if you're flat. And if there's several studies, older studies, that show that if you have the more areas it shows up in, like if it's in the pelvis and Morrison's, the pelvis, Morrison's, and by the spleen, it's more. So if I remember right, people that have it in all three areas have like 1,500 mils usually. So somewhere between 7 and 1,500. It's not a small amount though.
Right.
You're not
yeah.
going to have 50 cc's in there to see it. So
Yeah,
it's gonna be
response
significant.
operator curve studies, 50% of people can't see it at all at a half a liter. That's a good amount of blood to not be seen at all.
Yeah.
And then above that, 50% of people will be able to see it. All right.
Yeah,
Good
and
case.
the idea with transfer is just whatever is wrong, we're not going to do anything about. It's resuscitate.
That's
and
actually
move
kind of
them
my
on.
point.
Yeah.
Yeah.
If
Yeah.
they're bleeding, then they need to go.
So,
And one reason that you might want to just, I mean, you're probably going to do a CT scan in even a small hospital, but if you can skip it and let them do it at the
Definitely.
trauma center, they're probably going to redo it at the trauma center anyway if he
Yep.
needs IR embolization, because they want to know, is it bleeding? We don't care if it was bleeding 3 hours ago. We want to know if it's bleeding right now so we can go
Exactly.
do the IR procedure. Because if it's
Exactly.
not, if they can't figure out what's bleeding, they can't do the IR
It's a
procedure.
dynamic process. The whole thing may have changed by the time they get there.
What you just watched isn't just a great case, it's a game changer for acute care heroes like you. HQ MedEd, the pioneers in POCUS, who literally wrote the book on point of care ultrasound. We deliver unmatched educational expertise. Don't miss your chance to level up. Join us May 16th for our point of care ultrasound course. Head to hqmeded.com now to secure your spot and transform your practice.